Hi, I'm Dr. Brian Koffman, a retired family doctor and a CLL patient myself. I'm the co-founder, executive vice president, and chief medical officer of the CLL Society. Dr. Coombs?
Yeah, hi. My name is Dr. Catherine Coombs. I'm an associate clinical professor at the University of California, Irvine, where I focus on treating patients with CLL and SLL. Great to join you today.
Dr. Coombs, there's been a lot of changes in the way we treat CLL, and the pendulum has swung in a very interesting way. Originally, when I was diagnosed in 2005, really the only options were chemoimmunotherapy. And you did that for 6 months, if you could tolerate it for 6 months. And hopefully you got a long ride out of that. And then you did something else for a few months and something else. And then new therapies came out, and all of these were done continuously. And they were, in a number of landmark studies, found to be better therapies than chemoimmunotherapy for almost all patients, with some notable exceptions. But there was people stayed on meds, and there's good and bad about that. And that's kind of where we're going to go. There's been a shift towards getting people back using these novel, it's hard to call them novel when they've been out for more than a decade now, but these new targeted therapies, and which offer the patient the option of time off therapy. So if you have a patient in front of you and you have an option that would, it has the possibility of providing, or built into the way it's done, time off of therapy, how do you discuss that with the patient? What are the advantages you see as a physician? What are the advantages the patients are thinking about? And what are the disadvantages for time off of therapy?
Yeah, so I think it's such an important topic because I literally discuss this every time I'm in clinic with patients who are, needing to start a new therapy. And I think one of the fortunate aspects of specializing in CLL is that patients often aren't in a rush to start therapy. We do have the luxury usually of some time to think about what our options are and then what's the best fit based on a number of parameters. And so I think the first thing I'd like to mention is that I firmly believe there's not a one-size-fits-all approach for patients with CLL, but I strongly believe in offering patients the appropriate choices. And so the usual discussion that I have is when we're thinking about a patient's first treatment is either a treat to progression type therapy, as you mentioned, where the individual will go on a drug and stay on the drug as long as it's working and not having significant side effects, versus what I usually call a time-limited therapy. And so in 2024, when we're talking, our main FDA-approved novel regimen that is time-limited is the combination of venetoclax and obinutuzumab. And I think this is a really great approach for a lot of reasons. One is that there's a limited time in which the patient is on treatment, which is, essentially a year in the first line setting. And so that kind of gives, I believe, patients something to look forward to, an end game. And I think we also know all of these drugs can be costly. And so another advantage is when you're not needing to continue a therapy indefinitely, you are only having to pay whatever your out-of-pocket cost is for this defined period of time. A third advantage is when you're off therapy, you should not expect to have toxicities from that therapy. At least as of now, it doesn't seem like there are any delayed or late complications of this venetoclax and obinutuzumab regimen, which I think is one of the biggest differences between that and the old-fashioned chemoimmunotherapies that you speak of, where we can see delayed incidence of some very serious complications. So I'd say those are some of the benefits that I discuss with patients, but of course, there can be downsides. I think the main downside is the logistical considerations. And so the first 2 weeks when you embark upon this regimen can be pretty busy. Actually, I meant to say the first 2 months. And so as part of starting on venetoclax obinutuzumab, there's essentially once or twice a week visits for the first 2 months, which may detract some patients from embarking upon this therapy if they're the type of patient who prefers to minimize time in the clinic and maximize time at home. But otherwise, I see a lot of pluses with this approach. To take it one step further, there is a theoretical concern with the development of resistance mutations, which typically arise when one is on a continuous targeted type therapy where the CLL clone can then outsmart the actual therapy by developing a resistance mutation to the therapy. This doesn't seem to be seen in time-limited therapies because the kind of philosophy behind doing something over just a year is that you kind of knock the CLL down to such a low level, but then you stop before imposing this kind of continuous treatment that may allow the CLL kind of to escape by resisting it, by developing a mutation that allows that. So that's my general 2 cents on your answer, and I'm sure you have some follow-up questions for me.
And I have some follow-up comments. When we surveyed patients, this is going back several years ago when we presented this data at ASH, we found the big concern with chemoimmunotherapy wasn't the hair loss or the nausea or vomiting. It was those late onset adverse events. And they didn't, it's not like I'll get over, my hair will grow back. But if you develop a second malignancy, and some of the second malignancies, especially myelodysplastic syndromes and other things that are associated with some of the heavier chemotherapies, are pretty difficult to treat, much more difficult to treat than the CLL itself. So I think you're absolutely right about that it's reopened that ability to say, we're going to give you something that's a limited duration, and then you're going to be able to glide for a while and do that. Let me, I also want to focus in on this whole issue of resistance, and I'd like to get this, and this can get pretty speculative and pretty nerdy pretty quickly. So we're talking with patients here who have different levels of sophistication. But I have heard, that if you're not forcing the CLL, that if you in one direction by putting this therapeutic rope around it, that the only way to escape is to escape by mutating around the block point, that if you take that away, then it doesn't put this sort of pressure, Darwinian pressure, on the CLL to become resistant. But I've also heard that if you let the clone expand, and there's no pressure on it, you take the pressure off of it, that maybe, the cancer can grow a little more quickly, you're not keeping the pressure on it, and maybe you can get more resistance that way. Do we really know what happens here? What's the best approach in terms of, in terms of avoiding resistance? Because it's a long-term gain, right? No therapy at this point is curative. Some lucky few patients with a few wonderful exceptions are cured, but essentially it's going to be this therapy and the next therapy and the next therapy. So avoiding resistance is really important. So talk to me a little bit about what your thinking is as a CLL researcher in terms of not just this step, but the next step, and ways to avoid resistance, and how time off therapy might be helpful in that way.
Yeah, so I think you used a lot of the words that I use to describe how resistance happens. It's essentially you apply a selective pressure, which is blocking the part of the CLL cell that causes it to grow. But cancer cells try to always outsmart whatever therapy we're giving them. So as long as that pressure is there, there's the risk for the cancer cell to mutate to, again, grow around that pressure. We don't think this happens during our time-limited therapies, but, to answer the question that you asked of, is it better to do time-limited therapy? I think it might be, but I'll be honest, I don't think we really know that for sure. I think, honestly, patients do very well with both time-limited therapy as the front line, but also the continuous use of BTK inhibitors in the front line. most of the resistance mutations we see occur in much later lines of therapy, but I think they do eventually occur, but it takes a very, very long time when you're using kind of the alternate treatment, which is a continuous BTK inhibitor in the frontline setting. Is there truly a better? I actually don't think so. We don't have kind of the high level of evidence in our field to suggest that this one's better, that one's better. My own view and what I explain to my patients is these both work really well. They are just different. However, one thing that I like more about time limited therapy is that you have the option to try it again after the time off. And what is the chance of success? Well, that's actually, we don't know a lot about that because most patients who have gotten venetoclax and obinutuzumab as their first therapy, almost none have relapsed and needed therapy again. But I think that data will accumulate in the future years, but I would suspect it would work pretty well, and I think it'll work better the longer time you have off treatment. However, if we take the contrary approach, which is using a BTK inhibitor indefinitely, once that stops working, it's not an effective strategy to just switch to a different BTK inhibitor within the covalent class. Now, of course, there's a new drug that targets BTK a bit differently, where that is effective, but otherwise you can't just switch from one to the other, and you can't retreat because the way that the cells kind of get around the bottleneck and mutate, that's shared between all of our covalent BTK inhibitor drugs. So my main point is I don't think there's truly a better, but I think it is definitely a potential advantage to have the opportunity for retreatment where we would not have expected resistance mutations to have arisen because of that time off, where we lift that selective pressure or bottleneck that is exerted by the use of continuous therapies.
Right. And in the USA, the only approved limited duration therapy is venetoclax and obinutuzumab or venetoclax and rituximab. But there are actually a couple other exceptions that are approved. And these are the ultimate kind of time-limited therapies. A bone marrow transplant, which is kind of one and done. And now we have liso-cel, which is a CAR T therapy, which is kind of one and done too. So it is interesting to think that there are new kinds of options for patients that can be a limited duration. And there's a lot of trials going on of trying, what are the two best dancing partners together to see, is it a doublet, is it a triplet? There's all kinds of research that you and your colleagues are doing to figure out what the best way forward is. But right now we're getting really great results with the venetoclax and obinutuzumab. Any thoughts on any of these other combinations or the cellular therapies, the bone marrow transplant or liso-cel, because they really do, I had CAR T therapy, got 5 years off of treatment from that. So it was 1 month of misery, but 5 years of no therapy. So.
Yeah, I think you emphasized the most exciting aspect of liso-cel, which is that a subset of patients can have really good responses and have many, many years off of therapy. I think the overall response rate isn't quite as high as I would hope. It's certainly a lot lower for the other malignancies that we're using CAR T to treat. But nonetheless, I'm very excited to have this as an option for my patients who are of the mindset that I would be up for, a short-term tough time for the potential benefit of a longer-term remission. I would like to mention liso-cel is currently only available for patients who have had at least 2 prior lines of therapy that include both a covalent BTK inhibitor and venetoclax. So it's not something we're using earlier than that, but that could change in the future depending on what follow-up studies are done. Allogeneic stem cell transplant, as a, CLL specialist, I have done that, but I would say that's more the exception than the rule. And in general, I reserve this for patients who have essentially been failed by everything that is, within reason. And so I usually would consider this in patients who have progressed on, chemo, BTK inhibitor, venetoclax, non-covalent inhibitor, et cetera, because the toxicity of that is quite a bit worse than CAR T. And so now that CAR T is available, I don't see many scenarios where I would think about a transplant prior to CAR T. I would usually give CAR T a try first. So for your second question, I think I'm glad that we're bringing that up. I think it's a very unusual situation that something got approved in Europe and other countries, but not the US, which is the combination of ibrutinib and venetoclax. I definitely understand the reasoning, which is though the two drugs work very well together, there are unfortunate side effects that can occur with ibrutinib that fortunately we do have newer drugs that are a lot safer, primarily related to the cardiac risk. And so the drugs that I'm speaking about are acalabrutinib and zanubrutinib. And so as you alluded to, we do have some studies that will hopefully get an approval by the FDA for kind of, we call these oral doublets, which is the combination of venetoclax, but with a BTK inhibitor instead of obinutuzumab. And that the first approval that we might see is the combination of acalabrutinib and venetoclax based on this trial called the Amplify trial. There's another really good study that hopefully will read out in a few more years that recently kind of, acquired all the patients that they wanted to participate, called the MAGIC study, where the acala with ven are being compared to the venetoclax with obinutuzumab. And then the last study is one that I have open at UC Irvine that I'm really enthusiastic about. And so that one's a little different. It's using the BTK inhibitor called zanubrutinib, but with a newer version of venetoclax that's called sonrotoclax. And patients either get those two or the kind of standard of care therapy, venetoclax and obinutuzumab, but these are both time-limited regimens. So I think there's a lot to look forward to, and I think I personally would be pretty interested in an all-oral therapy if I knew that my options were going to work about the same, or maybe if the all-oral was even going to work better, assuming that it was approved and that my insurance paid for it. What are your thoughts on these ongoing studies?
Well, first I have to give the perspective that it's such an interesting world and things have moved. And I say the best advice in CLL is to get tomorrow's therapy because the therapies just keep improving. So I had a first remission transplant because there weren't options for people with 17p deletion and other things then. There was just really nothing where a transplant would be way down the line. And if I'd been diagnosed a couple of years later, I just would have jumped on PCI 32765, which later became ibrutinib, but that wasn't an option for me. But the transplant bought me enough time to get to the trial with an early phase 1 trial of what later became ibrutinib. So it's just amazing. And now transplants are still being used, but hardly at all. But at my time, they were not unusual at all for people to get a bone marrow transplant with CLL. It's just amazed how much it's moved. I think different patients are going to have different choices. It depends on their comorbidity. It depends on their preferences. It depends on what their insurance will pay for. It depends on what the data is going to show us in terms of that. But I think it's a pretty much, when we survey patients, certainly patients prefer oral meds to IV meds. But it's way down the line in terms of what they're really looking for. Is this drug going to keep me alive? Is it going to stop my cancer from progressing? Am I going to have few adverse events with it? These are much more important to patients than whether it's oral or IV. People are willing to put up with after the first month, it's a once-a-month IV for 5 more months. It's not that big of a deal. And most patients are certainly willing to accept that. I want to switch to another topic, and I know that this is something that's important to you because I know how you practice, and that is there's emotional aspects to this too. And you're treating that whole patient, and you're not just treating their blood or their nose. So talk to me a little bit about that. I'll just share my personal experience. When I was on a continuous therapy, it was difficult for me to stop it because that drug saved my life. And I didn't want to go off of it. It was my security blanket, like Linus from Peanuts and his security. I didn't want to give it up. My doc said, "You don't have any measurable disease. You don't have anything there. What are you treating? You're just, causing yourself risks and costing money, and it's not doing anything. There's no cancer there to treat at this point. It's such low levels." So for me, it was hard to give up, but I know other patients feel differently. What's been your experience on the emotional part of patients not being on any meds, but at some point knowing that they're not cured and the cancer is going to come back? Talk to me about that part, that emotional journey of being treatment free.
Yeah, I think it brings up another important aspect of caring for patients with CLL, which is that no, two patients are alike. And so I've definitely seen patients who really like being on continuous therapy because that is that security blanket, as you refer to. But I'd say maybe because it's just the patients I see or the way I present the data, I'd say it's more common for patients to really enjoy the time off therapy. And I think the added reason that time off therapy allows them that comfort, in addition to just the psychological aspects of not having to take a pill every day that reminds them of that cancer, is the fact that when we use venetoclax based approaches, we often are getting patients to a state of undetectable MRD, or measurable residual disease, as you mentioned, where if we send tests, I usually send them from the blood to spare patients from a bone marrow because there's pretty good agreement between those two places. Most patients are not going to have any detectable disease at the end of their year on therapy. And so though a security blanket is nice, and a lot of patients, do like that and like to be on something indefinitely, I think I can offer patients some reassurance when we get that end of treatment test that shows we can't even find CLL when we use a really kind of fancy test to look at very, very low levels. And it is with the knowledge that it will eventually come back, but I think the longer that we've been able to follow the original group of patients that were treated with this regimen, we know that that time can be quite long. 5+ years is kind of the median, which is similar to the average time off therapy following that original year on therapy. And then we have a lot of options whenever the patient's disease does come back. And so these are kind of, tidbits into the types of conversations that I have with my patients. But, I do see a lot of different feelings and opinions based on, what ultimately his or her comfort level is, which is not uniform. And I think that kind of prompts the reason for why patient-centered care and shared decision-making are so important, especially in CLL.
Final area that I want to touch on is one of what I see as a potential advantage, and correct me if I'm wrong, about being off of therapy, is that when we look at CLL, it's not just the disease, but it's the immunocompromised status that comes with the disease. And certainly the recent pandemic has really highlighted that. So are patients less immunocompromised when they're on these therapies? It seems to me that all these therapies are to some extent immunosuppressive, some more than others, not as bad as the old chemotherapies were. But the antibodies certainly are immunosuppressive, and all the drugs can, lead to problems. So talk to me about that, the effects on the immune system and rebuilding the immune system, maybe being off of therapy, and having a very low level of disease. Is that another potential advantage, or is that just me wishful thinking?
No, I do think it's an advantage, and the data to support that continue to evolve. One study that primarily was probably chemo patients looked at how well CLL patients respond to vaccination from COVID vaccines. And it looked like patients who had never been treated had the best response patients who were actively on treatment had the worst response, but patients who had distant treatment still had pretty good responses. And so that's one data point, but we're seeing emerging data for patients now with novel therapies who over time do develop some immune recovery. Now, it may not be totally normal, but it's better than being on active therapy, I think, in the great majority of cases. And that improves with time. And so the CD20 antibodies can lead to some delayed suppression of the immune system, which there's no day that it magically comes back, but the further one gets away from the CD20, the more immune recovery is achieved. And then
by CD20, we're talking obinutuzumab or Gazyva and rituximab.
That's right. That's right. Thank you for clarifying. Yeah, so I do think that is a potential benefit, and I think ongoing studies of the patients who have received these therapies with more measurements of immune function will help us understand that even more as time goes on.
Well, this has been very enlightening. Thank you so much. Any final thoughts for patients in terms of time off of therapy and how patients should think about it?
Yeah, I mean, I think my final thought kind of comes to your story, which is timing is really everything. And I really feel so thankful to be a CLL doctor, but I often get sad of the patients that I lost early on in my practice because we had a lot less options. And with every year that I've, been an attending physician, I think I'm in year 8 now, our options keep getting better and better. And I very, very infrequently lose a patient to CLL because it's becoming more and more treatable with more and more options. And I think our time-limited options are a class that offer so many benefits. And so, of course, the go-to in 2024 is venetoclax and obinutuzumab, but I think we're going to have even more options as the years go on. And I think that's just wonderful to decrease the chance of ever losing a patient to CLL in the future.
Well, I can't think of a better way to end a discussion on limited duration than the prospect of not losing a patient to CLL. That's just an incredible vision, and hopefully it comes to fruition sooner rather than later. Dr. Coombs, thanks so much for the research you're doing, the care you're giving to your patients. Thank you so much for all you're doing.
Yeah, thank you for having me and for all that you do, of course, through your advocacy.